So I'm going to talk about the overdiagnosis in pediatrics. So overdiagnosis has really been a topic that has mostly, I think, centered around cancer and cancer diagnosis. And I do speak from extremely personal experience about false positive mammograms, and that it sounds so easy to just do a stereotactic biopsy, just aim at the right spot. If they can't anesthetize you, that aim at the right spot thing still isn't all that easy, just saying. So I'm all in favor of a way of diagnosing DCIS appropriately that doesn't involve needles and things like that. So I'm going to talk about children, and although there are some cancer issues in children, really overdiagnosis in children is a relatively new thing and has been conceptualized somewhat differently than in adults. So pediatrics has come a bit late to this party. If you look at, so overdiagnosis is not yet an indexable term, but if you look at just the word in the title of an article, in all articles in Medline, there are 483 articles with the word overdiagnosis in the title. 30 of them also are indexed under child, but as I scanned through those, one of them was about prostate cancer, and I'm pretty sure that that child thing was unrelated. And only one of those articles relates to the current concept of overdiagnosis as Otis described it and as Barry described it earlier. So in pediatrics, there's really been very much an evolving definition of overdiagnosis because the term has been used. If you then go back and look at articles where the term appears anywhere in the title or abstract, you actually find the first one was in 1977, and really this wasn't overdiagnosis as we think of it now. It was misattribution, a sort of true unrelated. There was an article about the diagnosis of linea alba hernia. That means a hernia in the middle of the belly, as a cause of otherwise unexplained abdominal pain, and that article was about overdiagnosis. Go back a little further and not using the word overdiagnosis, but thinking about the epidemic of thyroid cancer, perhaps partly caused by something called status thymico-lymphaticus. I don't know if anybody in the room has ever diagnosed status thymico-lymphaticus, and we are reaching the point in time where there won't be anybody in the room who was diagnosed with this. But this was the discovery that children who died of sudden unexpected death, or SIDS, in the early 1900s, at autopsy had really quite large thymuses. So clearly the thymus was the problem. And the way you get rid of a big thymus is you irradiate it. And so you can get rid of the big thymus by irradiating it, and you can therefore prevent SIDS. It certainly works in a large proportion of cases because most people don't die of SIDS anyway. And so this was probably one of the triggers for large numbers of thyroid cancers that appeared a number of years later in people who had been irradiated for their large thymuses. So that was an overdiagnosis, but of a different kind, and that was the early pediatric conception. 1987, you started seeing articles about misdiagnosis called overdiagnosis. So overdiagnosing sinusitis. It's really hard to get sinusitis if you're a very young child. You actually don't have sinuses yet to speak of. And so it's hard to get sinusitis, but it was diagnosed anyway. And based on sinus opacity on x-ray, which it turns out lots of people have, whether or not they have sinusitis, or asthma based on a single episode of wheezing. So you saw articles in the literature using the word overdiagnosis, but in fact referring to what we would now say is misdiagnosis. Around 1991 was the beginning of articles about neuroblastoma. And this was the way we now conceptualize overdiagnosis, a true diagnosis, but without net clinical benefit. So from neuroblastoma screening. And then in 1998, you started seeing a lot of articles about over-medicalization, scope creep, overdiagnosis of, and the topic was ADHD, where the definition of the disease was being broadened. So I won't spend a lot of time on the first two other than what I've already said, but then I will talk a little bit more about the last two because I think that's where we are right now with the concept of overdiagnosis in pediatrics. So the focus in the pediatric literature early was misdiagnosis and resultant overtreatment, so otitis media and Anyone here who's ever worked in an emergency room and taken care of a pediatric patient knows that if you have a screaming child with a fever, you can imagine a red eardrum if you need to, so that you can prescribe an antibiotic to make the patient go away. And that actually is a kind of overdiagnosis, and certainly I will just guarantee that there's not anybody who's worked in a pediatric emergency room who hasn't had that experience. Sinusitis. Interestingly, there's actually quite a bit of literature about overdiagnosis of malaria, which I didn't know anything about, overdiagnosis of head lice, and then Lyme disease, as you can imagine. A true diagnosis, but with no benefit of treatment, would be neuroblastoma, food allergy, obstructive sleep apnea, bacteriuria, and vesicoureteral reflux, MCAT, which I'll talk about some more in a minute, and skull fracture. And then medicalizing variants of normal, I think, is another really big area in pediatrics. So ADHD, gastroesophageal reflux, disease or not disease, but reflux in any case, mild hypoxia and bronchiolitis, hyperbilirubinemia, and various pre-diseases, which those concepts have also entered the adult literature. So medicalizing variants of normal, and I think this probably, there's a talk later this morning that I think will be very interesting about ADHD and how we conceptualize this as overdiagnosis. But the issue that comes up is that lots and lots of kids are diagnosed with ADHD. But interestingly, the youngest children in a grade level are diagnosed far more often than the older children in the same grade level. And you can prevent ADHD by holding your child back for a year. Well, that really doesn't make a whole lot of sense. But what it does say is that we are making a diagnosis possibly not based on anything other than a behavioral pattern that's not in sync with the other kids in the class. Gastroesophageal reflux disease, I don't know how many people shared the experience that I had with my oldest child, where for the first year of his life, if I didn't keep a cloth diaper over my shoulder, I was going to have vomit down my back all day. And so, because he spit up all the time. He also weighed 30 pounds in a year, which is grossly overweight. So that spitting that he did, he was never unhappy about it. He was a happy spitter. But those kids get diagnosed with a disease and often get treated. So that's medicalizing a variant of normal. There's pre-disease, and we are doing a lot of pre-disease in pediatrics these days. Pre-hypertension, overweight, not obesity, overweight, hyperlipidemia in lower levels. And then hyperbilirubinemia, and this is the notion that having elevated bilirubin of any kind is somehow a risk factor for disease and needs to be treated. But note that bilirubin is actually an antioxidant. Nearly all infants have some elevation of bilirubin. In fact, pretty much all infants do, although not all infants are visibly jaundiced. About 50% of infants are visibly jaundiced. Is that disease, or is that medicalizing a normal variant? And then true diagnosis, but no net benefit from treatment. And the classic example, and one of the proven examples, is neuroblastoma. The screening test almost couldn't be easier. You put a piece of filter paper in the diaper and collect a wet piece of filter paper. And that is really easy to do. It's painless. There are no needles involved. And so easy test. But if you do that in 6-month-old babies, you see a sharp increase in early stage tumors, no change in end-stage tumors or tumor mortality. It turns out, and I think this goes back, actually, this is very much what Otis was talking about. Our conception of what was cancer was just not really quite right. It looked like cancer under the microscope, but a little baby, an under 1-year-old with a neuroblastoma, almost always those regress without treatment. So if you treat them, for one thing, you have to do an operation. These are not easy operations to get the adrenal out of a baby, or get the tumor out of an adrenal. And then you treat with not just surgery, but also chemotherapy, and you've clearly done harm. So these are biologically different. Identifying which are the ones that might not be different becomes the challenge. Exactly the same in neuroblastoma as it is in breast cancer or prostate cancer, just not quite so common. And then there's MCAT. So for those of you that have never heard of MCAT, I'll clarify this by telling you that it's medium chain acyl coenzyme A dehydrogenase deficiency. I'm sure that has clarified everything. So this is one of the things in the expanded newborn screening panel that we are now screening for in most states in this country. However, this is one of those things which we thought everybody that had this particular deficiency would end up with severe disease, because some people who have this deficiency end up with severe disease. It can be treated if it's diagnosed early. If you don't treat it early, irreparable harm is done. But then it turns out, now that we're doing all this screening, we're finding out that some infants never become symptomatic, and the treatment itself is quite burdensome. So this is a good example of a genetic disorder, a biochemical disorder that in some instances results in disease and in other doesn't. We thought we knew what this was, but we didn't. And then there's vesicoureteral reflux. So little girls in particular, but boys as well, get urinary tract infections and quite frequently have reflux of urine from the bladder up towards the kidneys, and this has been considered to be pathological. In fact, even high-grade reflux usually resolves over time, and even more importantly, the interventions that we do don't appear to change the outcome. So this is another example of what is probably a true diagnosis but no net benefit from treatment. There are adverse effects of overdiagnosis, obviously, that many of us are familiar with in the adult literature, but some of them are even more extreme in the pediatric population. So radiation risk is a terrific example. CT scans and chest x-rays. So if you work in the neonatal ICU, the daily chest x-ray is actually not that uncommon. Well, that's actually kind of a lot of radiation for somebody who only weighs 1,000 grams. CT scanning, and particularly when you only weigh 1,000 grams, or if you're a 2-year-old and you've just bonked your head but you actually look fine, many of those kids get CT scans and get overdiagnosed with tiny bleeds or linear skull fractures that are of no clinical consequence. 2 to 3 head CTs in an under 1-year-old triples the lifetime brain cancer risk. This is not insignificant. So just the testing alone carries a risk, and this isn't the risk that you think of with surgery or with a medication. This is a long-term risk that is preventable. Yes, brain cancer is quite rare. Tripling a very small number still results in a very small number, but it's unnecessary. And then there's what somebody called pediatric pathogenesis, the vulnerable child syndrome. So this was first described with these terms in 1964 related to innocent heart murmurs. So a kid with an innocent heart murmur diagnosed in the first year of life, a heart murmur that is nothing more than an extra sound that has no pathologic meaning. Half of those kids, over 40% of those kids in junior high school were being restricted from physical education and were told that they had something wrong with them. So that is a huge hazard just of making the diagnosis. Once you've made a diagnosis, you have someone who has a dis-ease, and they will have that disease forever. The disease label increased belief in medication, even knowing medication is not likely effective. This comes from a study of gastroesophageal reflux. And even parents who know that the medication is not effective, if their child has been diagnosed, are more likely to want the medication. Same condition, same symptoms, but if it has a label, they want the medications. The medications are not without harm. And then this is very interesting because it's relatively recent, and that is kids with food allergies. And close to 10% of kids have documented food allergies. A third of those kids are bullied, and they have measurable poorer quality of life from being bullied around that diagnosis of food allergies. So if the food allergy is not real, or if it's an IgE, meaning there's a biochemical test that says there's an allergy but the child never has symptoms, then you're placing them in harm's way just by making the diagnosis with no potential benefit. Then the remaining adverse effects really are things that we've already thought about and talked about. Harm because of resultant overtreatment, surgery for neuroblastoma, surgery for gastroesophageal reflux. Very rare, nobody does surgery on a happy spitter, but people do surgery for reflux and aspiration in kids with who are neurodevastated, and there are a lot of those kids. And it's simply not clear that that's beneficial yet. And vesicoureteral reflux, which also gets surgery perhaps when it's not necessary. Phototherapy in the newborn period for hyperbilirubinemia is intended to prevent kernicterus. Kernicterus is extremely rare. When it happens, it's devastating, but it's extremely rare. And since we started screening for hyperbilirubinemia and aggressively treating hyperbilirubinemia, the rate of kernicterus has not changed. But we are now aggressively screening and aggressively treating hyperbilirubinemia in the newborn period. So there is now some suggestive, not confirmed, data that says that phototherapy may be related to leukemia risk later on. And there's one randomized trial in the newborn period where an incidental finding, unexpected incidental finding, was increased mortality in the phototherapy arm. So there are reasons to think that this may not be a good thing. Besides the fact, and there are probably lots of people in the room who have had the experience, that when your kid is under phototherapy, you can't hold the baby because the kid is under the lights. They've got a mask on their face. They can't look at you. So there is some very clear disruption to bonding, and that has been documented at 6 months. You have changes in breastfeeding. You have changes in maternal-infant bonding for kids that have been under phototherapy. And then antibiotic resistance as an adverse effect because, for example, if you have vesicoureteral reflux, there are a large number of people who would give you prophylactic antibiotics to keep you from getting a urinary tract infection, but this, of course, contributes to antibiotic resistance. And then there's always cost, both financial and opportunity cost. It contributes to waste in the system. And if we think that in the American medical system, somewhere between 35 and 45% of our expenditures are attributable to waste, this is one of the big wastes right here, low-value care. And then, of course, opportunity cost is the opposite side. Having been on the U.S. Preventive Services Task Force, having made positive recommendations, which for pediatrics are vanishingly rare, but they are there. We do have some recommendations for things that are beneficial. People don't have time to do them. They're busy doing the stuff that isn't beneficial. So there's opportunity cost. So I would say that the way forward is medical education, primum non nocere, first to do no harm, teaching our medical students that doing something isn't what you should do all the time, and promoting comfort with uncertainty, which is really challenging. The students want to be certain. We demand that they be certain, and we are not helping them understand that sometimes you can't be certain. Quality measures. Vast majority of quality measures focus on underuse and on promoting greater use of something, whether it's appropriate or not. There's one of the extremely large outfits in the northwestern plains that shall go unnamed, has as one of its major quality measures whether people are getting their annual PSA. So that's a problem. So we should be looking at quality measures that help discourage overuse and overtesting and sort of thinking in terms of value-based care. We need to do research focusing on test value, not just on test accuracy, and lots of other research that we'll talk about in the course of this meeting, and then all the public campaigns that will help the public understand this. In my drive up I-95 last night, I was chatting with a friend who is a grade school teacher, and she asked me where I was going, and I said I was going to this conference, and we're talking about overdiagnosis, and she said, oh, tell me about that. Well, she's a grade school teacher. I said, well, let's talk about ADHD. And quite an interesting conversation with someone who is in the classroom and dealing with kids, and who actually clearly understood that many parents and teachers demand treatment for kids who are variants of normal, who don't actually have a disease. So there's the Choosing Wisely campaign, Safely Doing Less, Too Much Medicine, Less is More. There are all these campaigns that we should be helping and supporting. So the American Academy of Pediatrics did join the Choosing Wisely campaign. They didn't actually jump right on the bandwagon, but they did come. And these are their first 5. Don't use antibiotics for viral respiratory illness. Don't use cough and cold medications in little kids. Just don't do that. That's always been true. Use clinical observation instead of CT for minor head injury. Don't use CT or MRI for simple febrile seizures. And don't use CT for routine evaluation of abdominal pain. Well, this actually ended up being well received in the pediatric community, so 5 more things came up. Don't use high-dose steroids for BPD, which is bronchopulmonary dysplasia, or the lung disease that preemies get. Don't use screening IgE for food allergies. You need to use clinical history. You use your IgE as confirmatory, not screening. Do not treat physiologic gastroesophageal reflux. Don't treat the happy spitter. Just put the towel over the shoulder. Don't screen for asymptomatic bacteriuria, which used to be done all the time. When I was a resident, we had to get urines on all the kids who came in because they might have asymptomatic bacteriuria. If you treat it, you demonstrably make matters worse. Don't use home apnea monitors to prevent SIDS, or what is now called sudden and unexpected death. And then there are 5 more things because the neonatologists got on the bandwagon too. So just this last month, they published a paper saying don't use anti-reflux medications for GERD for apnea and desaturations in preterm infants, which is also commonly done. Stop presumptive antibiotics after 48 hours in asymptomatic infants. Don't get pre-discharge pneumograms, which is a test looking at how they breathe in preterm infants to see if they're going to have SIDS. It will not answer that question. Avoid daily chest x-rays. And don't get screening brain MRIs in preterm infants. So pediatrics is on the bandwagon. We're working on it, even if we came late to the party. Wise people saw this coming. Dick Berman, who is one of the real grandfathers of this, said this in 1996 before this became popular, and I think I won't read the whole thing, you can read, but I really like the end of it. Immediately leads to a higher diagnostic yield of the disease and a spectrum of milder disease, which then may be unnecessarily treated with pseudo-success. I think that's critical. And finally, don't just do something, stand there.